God, there was a good WhatsApp one who said that God, please don't shake the earth to find out where we are. We are in the houses only, don't worry.
Sir, we have around 50 attendees now, sir. So we'll start in 1 minute.
Yeah, I think let me connect my audio
Yes.
a little bit, and by then we'll start. Give me 1 minute.
Yes, sir. Meanwhile, I'll be introducing the panelist.
Guru, on a video on.
I will again say that whatever interest we have in congenital heart disease is because of our sir, Dr. Manoj, and he's a very dedicated person. And not only is teaching and his focus and sincerity and passion to teach students, especially finding them and bringing them in to teach. So we will always be indebted to sir. Good morning, sir.
We had Dr. Bidwai then. In fact, I remember Dr. Bidwai making the diagnosis of congenital heart disease only by putting stethoscope.
I think, sir, we can begin. Let's wait for Dr. UP Singh to join, sir. Once he gives us a green signal, we'll go ahead. So Vivek, you are operating right now, or you have doing only?
We are operating. We are doing after the COVID test only. We are operating. We are thrombolizing our patients, then shifting to isolation. After 2 days, we get a COVID report, and then we are operating them. The OPDs are closed. I am not doing any OPD, but I am operating. What about you in government hospital? What is it going on?
Our cath lab is under maintenance. It is being shifted to new building. So we'll be starting from this Monday or maybe Wednesday. Depends upon the ARB clearance. So, sir, we start, sir?
Yeah, please.
Okay. It's a great pleasure that we are back into PGI classes, and the third installment is on fetal echocardiography. It's a untouched subject for many of us, and therefore it raised many curiosity among us. I got many calls from my friends and my colleagues and my seniors that you have taken a very good subject where we had wished that we had a interference, but we could not do because of the time, lack of time or lack of because of binding of the other things. So Dr. UP Singh will be guiding us into fetal echocardiography today. With us on panel is Dr. Gurunath Parale. He is from Solapur. I think he is senior to Dr. UP Singh. We have Dr. Asif Hasan, sir, who is professor at Aligarh Muslim University in Cardiology. The Professor Dr. Rohit, sir, everyone knows about him, so he needs no introduction. He is like a god figure for many of us. Dr. Hitesh Gurjar, who is my batchmate also, and we have shared many serious and very naughty things during our cases, and many naughty things have been done on Dr. Vivek Mahajan, who is from Fortis, Mulund, Mumbai. He was our 6 months junior, and therefore often a very soft target, and we lovingly used to call him Bhau. We still call him Bhau. And so over to you, Dr. UP Singh.
All right. Okay. So we go to, okay.
The talk is interactive, so anyone can put a question or comment on the chat box, and we can unmute you, and we can have an interaction in case anywhere you want to clear a doubt or anything. So it's like a class in the PGI morning meet. We can have questions in the
okay, there is it. Okay, fine. So I'll share my screen. So we are set to go.
I would request the organizer, in case they can put off mics, unmute, mute the mics of the delegates. It would be nice. It took me about 2.5 decades to kind of starting my echo and presenting you today this talk, and various stages. And initially I thought fetal echo is something which is very, very casual and good, and it shouldn't be a problem, because I have done an echocardiogram, and I listened to the talks. This was the game changer in 2010. I was doing an echo for last about 4-5 years prior to that, so from 2005 probably onwards. And I thought that radiologists and gynecologists are talking about indirect signs of distance between aorta and LA, single vessel in 3-vessel view. And why should they talk about indirect signs when we can see things very clearly? But this was the time when I learned that why they were talking about indirect signs. The highlight was all indirect signs. They said TAPVC, total anomalous pulmonary venous drainage, would be difficult to diagnose if we are depending upon direct signs. I didn't believe that, but that was the time when there was an eye opener there, and this was for many. So I'm going to share my experience as it went, and the conference changed my view. I thought fetal echo is a kind of a shallow water like adult echo, but I was kind of different. From there to about a decade and a half, it was a very hard effort which we had to put in, and we quickly realized that the major issue is size. The heart at 20 weeks of gestation is about size of an almond. Okay, so then apna kaam kar lo. Now, because that put us into an issue that our equipments were not reasonable enough to see this size of structure. And then if you talk about looking at the VSD, the valves in a size of an almond, I mean, I can understand that this was really tough. So we required a very high temporal resolution. The heart rate was very fast. With the usual heart rate is about 130 to 150. And that is double the heart rate what we were accustomed to see as an adult cardiologist, and this requires a very high temporal resolution. Size was small, we required a high spatial resolution, and because we required these two resolutions, we didn't want to have a lot of noise. So I mean, both radiology equipment and cardiology equipment, the cardiology equipments, they were a kind of more on temporal resolution, and they were not good in spatial resolution. As in heart, we were not really concerned about noise cancellation. We loved speckles, we loved noise anyway. So the radiology equipment, on the contrary, were very poor on color Doppler frame rates. So both these equipments are kind of inadequate in this area. Till we got just 1 minute. So then this is the time when you need actually to improve the resolution. So in adult cardiology, it really doesn't matter if you have a big size of the sector or a small sector. The resolution, even if you try to do it in your echo, it won't make a very great difference unless you're trying to see a small thing. Here we are trying to see a small thing, and all those things which matter to improve frame rate are very, very critical in the diagnosis. So please focus on your machine for these critical areas. So we need to improve the frame rate. Rest, you being all cardiologists, you know what I'm talking about, the frame rate. You know about frame rate. You know about Nyquist limit. But something interesting which you probably may not be aware is that balance. There is something called balance. What is balance? Or some machines like in Philips, it's called priority. what is the priority, that what priority I'm giving to 2D and color Doppler when I'm displaying an image. If machine displays an image and if machine gives priority to the color would overwrite on the 2D information. But in case it is 2D, which is given more priority, 2D would be overriding the color data. So this is very, very important. I'm going to show you an example of a patient where this is the fetal echo, where the priority, look at the priority is kind of a balance. So you are giving preference to both almost equal. This line on the bar alongside the grayscale, this tells you the priority what you have, this green dot. And in case you increase the priority from this to this side, that means now the 2D is given less priority, color over information would override on 2D. And because of the poor azimuthal resolution, the color even behind and forward would kind of override on overwritten on the image. So you could see pulmonary veins very well. Majority of time the VSDs are not very clearly seen in case you have a balance which is given more towards the 2D. So 2D actually, on the 2D you don't see many a times an interventricular septal defect in the muscular variety, because the defect is either below this line or above because of the azimuthal issue. And then you have, if you keep the priority normal, and then you would be able to see color overriding or overwriting on the, so that's something important. This is the time our old physics, what we've learned while we're doing an echo, comes to handy. In fact, I did ARDMS, and in ARDMS, there's the full chapter, full paper you have to clear, that is ultrasound physics. So in that ultrasound physics, I again revised all what I learned. You have the lateral resolution and the axial resolution being the best, lateral being the second, and third or the worst is azimuthal resolution. This is the standard piezoelectric physics which we need to know. And what we see on the screen, please don't think that this is a razor thin image. And what you see is the structures behind also. So what you see is that structures which are behind and structures which are in front. So it's kind of a thick slice CT. So there is a lot of data which is overlapping. Now the 2D would overlap less, and the thickness of this slice would be more with color Doppler, because azimuthal resolution of color Doppler would be lower than azimuthal resolution of the 2D. So you would see the color Doppler data, which is actually may not be in the same plane what you're seeing. It may be behind or in the front. So you are unable to differentiate these two. These two would look on the same place on the monitor, but they're actually in a different position. This is an example to show that you have a pulmonary artery and aorta, because they are not on the same plane, obviously, and the pulmonary artery is not entering into aorta and coming out again. They are in those different planes, but because of the poor azimuthal resolution. So that is one of the reasons why we needed indirect signs. So I show you this example. Now, this is a dropout, and this dropout could be because of a thin perimembranous area of the septum, or it could be a VSD. Now, this dropout here, again, you see another dropout, and that's because of the poor lateral resolution of the 2D. And notice on the second video, this dropout is above the aortic valve. So this is distal to the aortic valve. So it's actually the sinus of Valsalva which has produced, which is thin and produced this dropout here. The VSD cannot be above the AV valve, the aortic valve. Now you see on a 2D, you see a dropout here. This is left ventricle, right ventricle, and you see a dropout here, and you see another dropout here. You're not sure whether it's a VSD or not a VSD. And what you do is that I've run this in a slow motion to make you appreciate there's no flow across the VSD. Okay, then if you notice here, if I stop this video and show you the place here, you see that there is some flow. You might think that this is the flow which is coming from RV, and this is overriding of aorta and it's going into the aorta. But if you see it little further, and that is what you see, this flow what you were seeing going, it is actually the pulmonary artery which is going behind the aorta. And then if I tilt the probe slightly, and then I start seeing the pulmonary artery, right? So that was the pulmonary artery flow. So there was no VSD. So understandably, and this is the real VSD. And why I say it is the real VSD, because if I stop it and show you, now this is the flow. Now this is the flow of the blood, and this is out of phase. There is no systolic flow here which is happening. There is no diastolic flow which is happening. It is in between that isovolumic contraction or relaxation, and then you see this flow. This is, I call it an out of phase flow. It is neither with the systolic phase nor with the diastolic phase. This is very specific for a ventricular septal defect. And to tell you something that you all, from your knowledge in adult cardiology and neonatal cardiology, you know that when the chamber pressures are same in RV and LV, there's hardly any color flow, or the gradients are so low that it becomes difficult to see the flow across those defects. Okay, so this same situation which is happening, RV and LV, the pressures are same, and you don't get a high gradient or high velocity flows. You have to, even in small VSD, the flow is a low velocity. You need a lot of patience when doing a fetal echo. I share this example. This is not very common, but I mean, it did happen in one patient. This is the patient where, we had apex pointing to about 2 or 3 o'clock position. And this is what we call as a lateral 4-chamber view. In this lateral 4-chamber view, please notice that the mitral valve and the tricuspid valve are looking okay, and I can't see anything, grossly abnormal, except for the right atrium and right ventricle are a little larger than aorta from LV and LA. And the baby turns, because I generally recommend that unless the heart is in the 11 o'clock or 1 o'clock position, apical 4-chamber, you must not leave that patient. So that takes time. Baby may not take a position, appropriate position. It might take hours, and it does take. We send the patient out, make them walk, make them eat something, and when there's a movement of the baby, and unfortunately babies sleep for a very long time, so movement are less in certain areas. Now in this patient, you see a very clear AVSD, and there's the same patient actually. Now this is a common AV canal defect, and if you miss a common AV canal defect, you had done the echo and the fetal echo, and you say, okay, it's fine, it's looking all right, I don't want to wait. Patient doesn't want to wait, and you don't have patience, and then this kind of abnormality can be missed. And missing an AVSD is catastrophic, because you miss so many association of AVSD, in particular trisomy 21. So this just reminds me and old illusions which we all used to see. So you have to have a proper view, and the illusion was that this is a horse which we can all see, but the moment you see it from a different angle, it looks like a frog. So you need a lot of patience. That is the first message which I want to give you. Until you get all the views, I don't think so you should be. There are good internet sources. You can browse those. You can actually go to the ISOG guidelines, ISUOG guidelines. And these guidelines are published for screening of the fetal heart, and they are given a couple of views which you all must take all the views before you satisfy yourself that we've done well. Now, so with this concept, and we because slight change in position would you mess up important thing. slight resolution issue, you mess up an important thing, you miss VSD, AVSD, TGA. So then we said, forget about that, direct signs. Let's have some direct signs or clues or red flags, which actually should guard us that not be very quick and hasty in decision making. Now, this is one pulmonary vein in the fetus. This is another pulmonary vein in the fetus, which is entering into left atrium. Done. So then same on a color Doppler. So what would happen if I have a patient of TAPVC? So I would have just this one line, that the roof of the left atrium. So if I have a roof of the left atrium, then it is normal. If I then this becomes a TAPVC. If there is no roof which I see here, this becomes a normal. So just missing this small line, you would miss the diagnosis of a TAPVC. And till 2002, the accuracy of pickup of TAPVC was about 2%. So we missed almost all patients of TAPVC. Till then we realized, let's look at the indirect signs of TAPVC. This is the pulmonary vein, which is actually, in case you don't see this line, this ridge, then you would presume that this pulmonary vein is entering into left atrium, and with the poor resolution, the color actually bleeds. And if your filter settings are not okay, this color would bleed and it would look as if pulmonary vein is entering into the left atrium. So you would miss an important disease that is called TAPVC. So we developed this indirect signs. Indirect signs is that the aorta is very close with the left atrium, and in case the distance increases, because pulmonary veins are supposed to anchor the heart posteriorly, and that's the only thing which anchors the heart apart from the pericardium, then the distance increases, and the distance increases because there is a posterior chamber. If you see a small twig, I would show you an example, a twig behind the left atrium, this is an indirect sign, and this is what is the posterior chamber. And if you not see a twig, but you see the distance increased, this is also an indirect sign with the sensitivity of about 95%. So now at the side, you can have a twig sign. You can see LA is a kind of bald. LA is punctured by the pulmonary veins and becomes little boxy. And in case the LA wall or the superior wall is rounded like right atrium, that means the pulmonary veins have not punctured the LA, and then it is a TAPVC. That's another indirect sign. Then you see a dilated coronary sinus and you don't see left superior vena cava. You strongly suspect TAPVC directly on entering there. And you see an increased brachiocephalic flow when you see a vertical vein also on one side and SVC on the other. Then there you see a turbulence in the hepatic vein, and then you think of a suspect infracardiac TAPVC. So that is what we have. The LA is bald. You have a twig sign. This is a posterior chamber. So this is an indirect sign. I used my knowledge of Coumadin ridge, because we all knew that there is a Coumadin ridge, because by mistake, Coumadin used to be started in patients on seeing on T this as a thrombus or something. That's why the name of a Coumadin ridge comes from there. This is the left atrium, left atrial appendage, and this is the pulmonary vein, left upper pulmonary vein, and they form a kind of a fold inside the left atrium. This ridge is, we used to call it a Coumadin ridge, and this is what it is. And we described that if you do not have a Coumadin ridge, that means the pulmonary vein has not punctured into the pulmonary vein. Left upper pulmonary vein is essential to create that ridge apart from left atrial appendage. So if the ridge is missing, and then you can make a diagnosis of this was another indirect sign for a TAPVC. Let's talk about TGA, which is fairly easy or reasonably okay to pick up on neonatal or an adult echo. And what we see is that on a cross-sectional Sachs view, where you have an aortic valve, the pulmonary artery normally is seen like a circle and saucer appearance. But in case you have anteriorly placed aorta, this is transposition of great arteries. Then you have a pulmonary artery which is branching, and the size of the pulmonary artery neonate is really good. You can see the branching. Let me tell you, we can see the branching in the fetal heart, but the pulmonary arteries are small. Now, pulmonary artery in the fetus divides into three. One is the left pulmonary artery and a right pulmonary artery, and third is the ductus. So ductus arteriosus is the biggest branch, okay? And pulmonary arteries are smaller branch because the pulmonary flow is about 10 to 12% in the fetus. So pulmonary arteries and pulmonary veins are all small because very small quantity, about 10% of the cardiac output goes to the lungs. Rest is all diverted from right ventricle through the ductus into the descending aorta. So we thought it's very easy, and that was a kind of the pickup rate of a TAPVC, of a TGA. And with the current guidelines, it has actually improved, but still we are missing a sizable number, about 30% of them on of a TGA. And that's what, how do we diagnose this TGA? Let me tell you, even about 3 days back, after two decades of fetal echo, I was scanning a fetus for a fetal heart, and all previous previous ultrasound reports said cardia is normal. And I got just one abnormal sign, that is I sign on a 3 vessel view. I'll show you what is that sign. And I couldn't get a proper 3 vessel view because the spine was anterior and I was not seeing the things well. If I had presumed that everything is okay, I would have sent that patient. I asked the patient to wait again for some time, and fortunately the baby's spine went back, and it was ventral position now, and we could see a transposition of great arteries. So I was so close of missing a transposition of great arteries. In transposition, you get the chambers, LV, RV, RH, they are all normal. 4 chamber is absolutely normal with no clue. And if you are not cautious, you see one artery coming off the LV and you might presume this is aorta, then it's done. Then you miss almost everything. The very important thing that we must have a crossover. Aorta and PA usually cross little less than 90%, about 90 degree from each other, and they cross each other at about 90 degree. And this crossover rules out transposition of great artery. That's very, very important. The next thing is that we should see parallel vessels. So this is one vessel, this is another vessel, this is pulmonary artery. And as I told you, we don't see the branching of the pulmonary artery well in the fetal heart because of the resolution issue. Now, and we want to diagnose before 20 weeks because many parents would like to take decision. Now, this is a pulmonary artery and that's an aorta. Okay, so then these 2 vessels are parallel; they're not crossing each other. If they're not crossing each other, like in this patient, the vessels are parallel to each other. The 2 blue shades, what you see. So this means this is a transposition of great artery. What are the indirect signs or clues which we should look for? Now, generally, the pulmonary artery, the vessel arising from LV, which actually is aorta, but in this case, it is pulmonary artery, then the pulmonary artery is slightly larger than aorta. So if you see a little larger vessel coming out of the aorta, I mean, that's just, 6th sense. And then you say that, okay, there's something wrong. Then we see 2 vessels instead of 3 vessels in 3 vessel trachea view. I would tell you what is 3 vessel trachea view in a very short while. This is the trachea cross section. This is the superior vena cava. As we see, then you have an aorta and a pulmonary artery. So now this is called 3 vessel, 1 vein and 2 arteries. And in case you don't have this situation, then what happens? In this situation, you get a curvature towards the left side. This is the left side. SVC is on the right side. So this is the curvature on the left side, what you see. And if you have an aorta, which is in a transposition of great arteries, the curvature is on the right side. So this is another sign, smile sign, eye sign, a lot of names given to it. But basic idea is the aorta arches from the right side here, and it does not cross through the pulmonary artery to arch on the left side as well. It continues to arch above, right? So this is an aorta, and this aorta curvature is towards the, and this was the only clue in that patient. And slight angulation, there was a 3-vessel view also, but this was the only clue of curvature towards the right side, which made me ask the patient to wait and to see again. If I had not done that, I was just close to miss that important. And why we get in a 3-vessel view, one vessel or one artery rather than 2 arteries, is that now in TGA, aorta and pulmonary artery are, they don't cross each other at any level, and pulmonary artery continues to dip down posteriorly, and it lies under the arch. The pulmonary arch lies under the arch of the aorta, and if you section it one place, you'll see aorta. If you section it another place, you'll see the pulmonary artery. So in 3-vessel view, you see just one artery, and then this is the superior vena cava. And this actually, now in this condition also, you see the curvature is towards the right. So SVC is on the right side of the body. We developed a few special signs, and one of the very, very special sign by Dr. Yu, who actually named it a 3-vessel view, 3-vessel trachea view. Now, in the 3-vessel trachea view, we are transecting at this level superior vena cava, aorta, pulmonary artery, and at the level of the ductus. And this is what you see. PA, you see aorta, and you see SVC, and you see the trachea. And that's what you see on a color Doppler. This is the diagrammatic representation. And then you see a thymus in the front of the aorta, and the distance from aorta to this and posteriorly, there is a ratio which we can actually measure and make an assessment of size of the thymus. And you all know that if you have a thymus hypoplasia, you can be dealing with the microdeletion or DiGeorge syndrome. So that was again which I showed you. Now it gave us a lot of benefits. So now we would do an abdominal view for the situs. We would do a 4-chamber view, and then a 3-vessel view. These views would pick up about 90% of the patients. And if you add LVOT and RVOT view, and that would complete your set. Now, the relative size of aorta, great arteries, you may not be able to appreciate if you are seeing in the arches, but in this place, you would see both simultaneously, and you can compare the size. For example, a small size of a pulmonary artery would actually tell you this is a pulmonary stenosis. A smaller size of aorta in the arch would tell you that this is a coarctation of aorta, which is a tubular in nature. And then you can see the flow direction, arch abnormalities. I think I'll show you the cases. So if you do 4-chamber view and 3VT, you are fairly okay. How do you achieve this? You, from the 4-chamber view, you go cranially, LVOT, and then you go still cranially, you get an RVOT. You go cranially and rotate the probe slightly to the left, and then you would get a 3-vessel trachea view. And these are the structures what we see on a 3-vessel trachea view, and both the vessels show the blood flow going in the same direction. That's very, very important. So in case you have an aorta and smaller, just examples, so I won't go into greater details because you can pick up a lot of abnormalities in 3-vessel view. If aorta is small and the flow is antegrade, this is a coarctation of aorta, or interruption of aortic arch, or some other abnormality. But in case the aorta is small and your flow is retrograde, that means the flow is not coming from LV, this is filling from the pulmonary artery, and then it arouses a suspicion that this could be aortic atresia, it could be a hypoplastic left heart syndrome. And that's one patient where aorta is seen in red color, that means it's flow towards the probe, and pulmonary artery is in different direction. And when you interrogate further, this is a patient of a hypoplastic left heart syndrome is unable to generate blood into the aorta, and the aortic valve is atretic and it's flowing from the pulmonary artery through the ductus. Then there are, on a 3-vessel view, other important things like right-sided aortic arch. For example, right-sided aortic arch is not a very important thing because it's not pathological. It doesn't create a great problem, doesn't create a vascular sting in majority of the patient when you have a left ductus. So it's only that trachea comes in the middle. Normally trachea should be on the side. Trachea comes in the middle and aorta goes from the right side of the aorta. Okay, the SVC is on the right side. So it goes from the right side of the aorta, where the normal should have been the left side of the trachea. If the aorta goes from the right of the trachea, so that means this is the right-sided aortic arch. It's not very pathological, but the issue is that if you see a right-sided aortic arch, you might like to see other structures, and you might like to rule out a microdeletion 22q11, that is DiGeorge syndrome. There's another thing, that anomalous origin of right subclavian artery, anomalous origin, this is called as URSA in short. And if you see this URSA, there has been an association with the trisomy 21, and we should do some further testing. Another special view is the situs, and if you have, this is the abdominal view, and then you have an inferior vena cava, you have an aorta on the left side, stomach, and a umbilical vein, which after giving a ductus venosus turns to the right portal sinus, and that's the gallbladder, what you see. And all these structures are important, and there is a very good way of seeing the situs, because in a neonate, how do we used to see the situs? We used to call it situs ambiguous when we used to see stomach in the midline, and the liver in the midline, and stomach in we were unable to appreciate well, and because it's filled by gas. But stomach is very clearly seen in the fetal circulation. So if you see aorta, stomach, and umbilical vein 1, 2, 3 in a clockwise position, and you move your probe caudally towards the mother's feet, and if you see the heart, or if you see sky further, you know that head is towards the caudal position. That means this is situs solitus. So same, if it is in anti-clockwise, the fetus head should be cranial. Fetal head should be upwards, should be superior. So if this is there, then this is situs solitus. But if this does not meet that criteria, if the answer is not yes, so then it is stomach. What you see stomach there is not the left side of the fetus, it's the right side of the fetus. So this is how we make the assessment of the situs. And if I don't follow this rule, that stomach is on which side, is it on the right or the left, I probably would miss all patients of situs inversus totalis. So now, how do we diagnose a right and left isomerism? It is simple that left and right isomerisms we diagnose because the stomach can be in any position. So that's not a clue. Stomach can be on the right side, stomach can be on the left side. But the issue is that if you see a juxtaposed arteries, either on the right or on the left, you see juxtaposed that both superior vena cava and aorta on the same side, that indicates right isomerism. And in the left isomerism, there is interruption of the inferior vena cava, and you see a vein side by side of the aorta, and this vein is actually azygos or hemiazygos, depending upon the side which is present. And this is a continuation of the inferior circulation by hemiazygos or iazygos vein. So if you see vein and artery side by side, this is left isomerism. If you see anteroposterior on the same side, that is a right isomerism. So there are the clues what we get to see. Something I want to tell you, because this is the parallel circulation in the fetus. So I mean, it's not in series. So if the blood has an obstruction on the left side, it starts flowing from the right side because you have a fossa valis, you have a ductus there. Okay, so there are many ways that the blood would, and wherever blood flow is there, that's an important determinant of actually the growth of that ventricle or an artery. Okay, so wherever the blood goes, it actually continues to grow, and the blood does not go on one side. That is, let's say if the blood, because of mitral stenosis, does not go into the LV, and the LV becomes small, and eventually it becomes hypoplastic LV. So there are no gradients usually. So what is in the parallel circulation, you have a fossa valis where the mixture happens, you have a ductus venosus, and then you have a ductus arteriosus. For example, I give you an example. If there is the LV, let's say if there is aorta which is atretic, let's say aortic valve is atretic or severely stenotic, just aortic stenosis, severe. Now the blood would not, normally the blood would come from fossa valis from RA to LA. Now, because of the resistance ahead, the less blood would come on this side. More of the blood from fossa valis will go to the RV, would go into the pulmonary artery, to the ductus, would supply the arch of aorta, would supply the descending aorta also. The circulation is complete. So there's no deficiency. With the period of time, the LV starts becoming small. Mitral valve starts becoming small. So this entire chamber becomes small, and it becomes an hypoplastic left heart syndrome. That's what is a genesis of hypoplastic left heart syndrome. In case you have a restrictive fossa valis, you have a problem or obstruction of the mitral valve, you have a problem in the aortic valve. All these three conditions can lead to a hypoplastic left heart syndrome. So for example, I show you a patient with a tetralogy of Fallot's, and this is the left ventricle, this is the right ventricle, and you can see the aorta, which is overriding with a large VSD. And but if you see here, the pulmonary artery is small. Okay, and if you see the gradients, hardly any. The pulmonary artery velocity is increased than normal, but is still in the normal range. It's about 1 meter per second. So the pulmonary stenosis is represented by a small pulmonary artery because less flow is going through this. So if you want to make a diagnosis of TOF and you are looking for a large gradient like we used to get at 4 meter or 5 meter across the pulmonary artery, you won't be getting that. A very interesting case I've showed many times. The previous child has a Gaucher disease, and the proven, and this time everything was fine. The studies were done, and you see LV, RV, they are fine. Mitral valve is looking okay. Tricuspid valve is looking okay. The clue here is the fossa valis. Normally, the blood comes into the right atrium through the all the veins, and the blood should go from here to the left. The fossa valis always beyond doubt should bulge on the left side. Now this fossa valis is not bulging to the left side, it's bulging to the right side. That is the clue. Now you move on. You want to see, okay, there got to be some obstruction somewhere. Mitral valve looking okay. The LV is looking fine. So there must be aortic atresia or something. That is why the fossa is bulging to the left side, to the right side. So what is going wrong here? Okay. So then we did, there was, to tell you the truth, there was no aortic valve abnormality. The aorta was perfectly fine. And you see the flow across the mitral valve. This size of the jet is smaller. This is what we are using is a power Doppler. There is a tricuspid regurgitation. Now, if you use a color Doppler and you get the Nyquist limit down, you start seeing the aliasing across the mitral valve. And these were the kind of best gradients across the mitral valve. So this was a mild gradient which you get across the mitral valve. So this was the patient of a mitral stenosis. Again, it is known in Gaucher disease. How did we make a diagnosis of coarctation of aorta? You did a suprasternal view and you saw aliasing blood, and you see high velocity systolic and diastolic, and you saw a lot of turbulence. You saw the narrowing here, all the things, and then you said, okay, this is coarctation. Do we get this kind of luxury in the fetus? No, because there is no gradient. If I may tell you that isthmus in normally is the narrowest portion in the entire aortic arch. Okay, that's physiological. Why? LV pumps blood into the aorta, it goes to cerebral circulation and arms, and the RV pumps blood into through the ductus into descending aorta. There's some streaming here, and this becomes a kind of a watershed area. There's hardly any flow or a very markedly reduced flow in the isthmus. Okay, so isthmus is a watershed area. So what happens now if you have a coarctation, more of the blood, if you have a coarctation here, now the more of the blood from the left side, because it's finding resistance here, more of the blood from fossa valis would go into the right side. Okay, so now the sign of coarctation of aorta, the indirect sign of coarctation of aorta in large majority of patients is dilated RA and RV, and you don't have any other clue. So if you don't have any other clue, if you have an RA-RV dilated, a very strong possibility of a coarctation of aorta has to be kept. You may be lucky enough to see the coarctation, but this happens in less than 10% of the patients. In a majority of the patients, if you depend upon this, the sensitivity of this sign of coarctation is very low, and the sensitivity of this RA-RV dilatation is high, and we know that there are many other causes of RA-RV dilatation. The specificity is less. An interesting situation where fetus behaves like a constrictive pericarditis, because in the adult or in the child you have lungs which are airy, so there is a lot of expansion which can happen in the heart, but because of the solid lungs, so in case there is any dilatation of one of the ventricles, the lungs are not going to cooperate. They remain stiff. So now this behaves like a constrictive pericarditis. So that means it becomes a kind of ventricular independence. We had one patient where there was a absent of the aortic valve, and this was very, very rare. One cusp of the aortic valve was missing, and this was the first case in the literature ever with the one cusp of missing and diagnosed in the prenatal situation. There were two cases which were reported postnatally, actually. So now in this, the blood going forward and the entire blood, there's a torrential aortic regurgitation. And if you see here, look at the LV. LV contractility is bad. On the right panel, if you look at the RV contractility also is bad. What is happening is because of the ventricular interdependence. So this is the normal M mode, what you would get, an RV contraction, simultaneous LV contraction. Interventricular septum in the fetus doesn't contribute on either side much. But in this patient, what we had, this is where the ventricular contraction is happening, and this is where the interventricular septum contraction is happening. This is where the right ventricular contraction is happening. They are all haphazard. When LV is contracting, the septum is not, going with it. So it is kind of a tram, So hardly anything is moving. There is, so you can see, this is what I want to say, that interventricular dependence. Let's say if you have a right-sided pathology and you drew a tie index of the left side, it would be abnormal. Okay, so it's very, very rare to have a single ventricle which is bad, another ventricle is not affected. Particularly when it's dilated. I'm not talking when it's small. So how do we diagnose tamponade then? Because we used to depend upon all those signs of, if all fetal hearts are kind of CCP, then how do we diagnose tamponade? Our old method of diagnosing tamponade of a swinging heart motion in the chamber is the only clue what we have in the fetus. Otherwise, it's not possible for us to make a diagnosis. This was another case which was the only case published in the literature. This was exudates and you see the swinging motion, and these exudates are there anteriorly, posteriorly, all around the heart, we thought it is exudate because we saw this kind of condition in tubercular pericardial effusions. So I thought this is all the tests relating to infection, viral and bacterial, were negative. And what we did, and this is what we saw. And immediately after birth, the neonatal again showed a large pericardial effusion and confirmed the signs of pericardial tamponade. We took out about 70 ml of hemorrhagic fluid, and everything was absolutely normal. So those were all actually clots in the pericardium. So it was a hemopericardium, spontaneous, no cause. This is about 3 years now, and the child is going fine. Now we have a couple of varied structures in the heart. Ductus arteriosus, which is not a very, very important thing in any other situation, but in the fetus, because the RV, the majority, about 90% of the blood from the RV would actually go through the ductus into the descending aorta. God forbid something happens to the ductus, RV would actually choke. The RV would get into problem of a markedly increased afterload. And this is what happened. There are a couple of factors which maintain patency of the ductus arteriosus in the fetus, and you neonatologists and adults, you all know these factors very well, which actually maintain the ductus patency. Ductus becomes sensitive to these modulations after sometimes. In case you are taking any offending agent which can cause ductal restriction, would produce an RV overload, and it can eventually lead on to fetal hydrops and demise if you do not rectify the basic problem. And these are the drugs which can do it. But I didn't show you the slide to show you this. My idea was to show you this. Polyphenols and flavonoids, which in normal person, they're degraded so quickly in the prostaglandins in the lungs, in the body, in the stomach, and in the circulation, that you don't get any major effect of flavonoids and polyphenols in the body. But because of the flow going to the fetal heart, and fetal doesn't have prostaglandin destruction material that is mainly in the lungs, now even green tea, dark chocolate, red wine, plums can actually produce it. And we did publish one case report where the lady was putting a anti-stretch cream on the belly, and obviously was putting on a large area. And this salt, mangista, which is Rubia cardiofolia, has been shown to be of an anti-inflammatory properties. And this was actually causing a ductal restriction. And there are host source, you can go on the net, and please tell your pregnant women that they should not be taking a large quantities of sources of polyphenols, because they can produce ductal restriction and can lead to a problem or even persistent pulmonary artery hypertension in a postnatal period. One of the causes is ductal restriction. Ductus venosus is again important. It does two things, very, very important. One is that the umbilical venous flow is very high velocity, high pressure. Now, if I subject the right atrium to this kind of an arterial flow, okay, so the right side would face a lot of the preload. So what we do, nature has done, it's created a valve here. Now, valve is supposed to do two things. The valve here of the ductus venosus does, one is that it reduces the pressure of the umbilical vein going into the right atrium. Then, and secondly, it makes a jet. That jet through the Eustachian valve goes selectively to the left side. So this is streaming of the blood, so that an oxygenated blood from placenta reaches the left atrium and ventricle for cerebral circulation. But by chance, if that ductus venosus is absent, and it's not very, very rare condition, we see it quite, it's uncommon, but we've seen number of patients now. And this is the patient where umbilical vein directly opens into the right atrium. And this is the umbilical vein. It goes anterior to the liver to open into the right atrium. That is the entire circulation. This is descending aorta. And then this is the umbilical vein, which goes and directly opens into the right atrium. So if it opens into the right atrium, as I told you, the problems happen. Problem happens that liver is a very critical, important thing for the growth of the fetus. Now, the blood is shunted from the liver and it goes directly to the heart. Then there are complications, and there could be absence of pulmonary portal venous system, which again produces a lot of difficulty after the child is born. And the umbilical vein, if opens otherwise, would lead to a lot of pressure problems. So not going into the details, it produces not only the shunting of the blood. Now there are two things: the blood properly would not be shunted to the left side, so the right atrium and ventricle would dilate because of the pressure. If I show this video on a clip to an adult cardiologist, a very clear diagnosis would come out. That is, there is an akinesia of apical segments in LAD territory, and maybe this is a large apical left ventricle aneurysm. And you asked guys would start thinking on the left anterior descending artery territory. But you know, I reviewed the literature and found out the regeneration in the heart is not, it regenerates. What they did was they occluded one of the arteries and in an experimental animal, and they produced myocardial infarction. 4 weeks when the sheep were, the feti were examined, there was no clue where the infarction happened. It all regenerated. So in adults, the myocardial regeneration doesn't happen. Now there's a lot of research going on, and you all guys know that the regeneration in adult myocardium is very, very important, even if small. But myocardial regeneration is almost full. There is no inflammation. There are no inflammatory cells. There no scarring happens. So this is the slide. So that means the reason for a ventricular aneurysm in the fetus is not the CAD. It is the defect in the ventricular wall. So then, the tumors are very different. What we see in the fetus, and again, not very uncommon. And these are the multiple rhabdomyomas. When you see a tumor in the fetal heart, the more than 90% chance is that you are dealing with the rhabdomyoma. These tend to resolve of their own after postnatal life because of lack of estrogen hormone, and they are hormone dependent growth, and they actually disappear, and they are generally not the concern. Concern is the tumors which happen in the brain, because these are generally associated with tuberous sclerosis and intractable epilepsy because of those tumors is a major issue. And these tumors could be very large. Very large tumors can actually produce some obstructive signs, and these are all rhabdomyomas. As I told you, a mild aortic stenosis becomes a severe aortic stenosis, and a severe aortic stenosis becomes hypoplastic left heart, because if you get an early, a mild AS in an early gestation, 8 weeks or 10 weeks, and then this is highly likely to progress to lipoplastic left heart syndrome. And then, obviously, when this kind of situation happens, you have a problem because ductal dependent circulation and the single ventricle repair is the only option. So another issue, I think this is the last one I would cover, and then we'll stop here. I'm already speaking for about an hour. Now, this is a cardiomegaly. In a cardiomegaly of the neonate or the adult, it would not be a very great deal. I give you this example that this is a patient of an Epstein, and this is the patient of a tricuspid dysplasia or a dysplastic tricuspid valve, and both because of the severe regurgitation has increased left-right atrium. And this, because it's a right-sided circulation, is not really very, very important in a postnatal life, but in the prenatal life, this cardiomegaly has actually squeezed the lungs. So it has produced a pulmonary hypoplasia. So when this child is born, there are two difficulties when the right-sided issue, and second would be the pulmonary hypoplasia. So in arrhythmias, how do we diagnose arrhythmias? Do we? Yes, we do diagnose arrhythmias in the fetus, and we do indirect, we call it a mechanical indices of ECG. What are the mechanical indices? That a TP interval is represented by E wave, and the A wave is represented by, then obviously, the atrial contraction, and this is the representation of QT interval. So now, if I do an inflow and outflow signal, I get both, aortic flow and the inflow simultaneously, because we are very close. So simultaneous LV inflow and outflow, if we take the inflow A wave would give me atrial activity, and the left ventricular outflow would give me a ventricular activity. So the ventricular activity would represent a Q wave, and atrial activity or an A wave would represent a P wave. So from this, we can kind of devise. Similarly, we take an M mode, and M mode passes from one ventricle and one atrium. Any ventricle, any atrium is okay. And you see the ventricular activity, you see the atrial activity, and then you know that this. So this is one of the patients with the 4:3 AV block, and this is one conducted beat, another conducted. This is the atrium, and you can see the atrial contraction. This is the ventricle. So this, I presume, is a P wave. This, I presume, is a R wave, and this is how it is conducting, and this one is actually blocked. There is no conduction, there is no ventricular activity down there. So this is how we diagnose arrhythmia. But more important than that, we are moving more and more forward. There is a recent paper last year that we can actually make an assessment of a QT interval also. I won't go into the details, but I am more interested in finding out prolonged PR interval, because if I have detected a patient of a prolonged PR interval in a pregnancy who previously had SLE related complete heart block, she's pregnant again. And in this, if I find a AV block, complete AV block, no drug is going to work here. If I find a prolonged PR interval, maybe steroid and other things might help in this area. So I am interested to know what is PR interval, and we do it from the onset of the A wave to the onset of the ventricular activity. And this is what we call as a mechanical PR. So this is the patient where the mechanical PR is prolonged. If it is more than normal, it's about 125 to 130. But if it's prolonged more than 150, is abnormal. 160 is diagnostic. So this is what I published a little long while. Those of you interested in the same thing, this is exactly same thing which I shared my experience on this review. And thank you very much for your kind attention.
Thank you, sir. I think you have kindled interest in fetal echocardiography in many of the cardiologists. And this talk not only would go in a long way in making them more interested here. There are few questions, sir. Dr. Ajay Agarwal has asked how to acquire ductal arch, aortic arch, and IVCs in interrogating a fetal heart. And on my end, how we start, because since you have initiated many of the cardiologists to look into this new field, how for beginners it would be what would be your how they can come into doing cardiography?
I think there are a couple of things which are important. I take your second question first. That how should a beginner or who is not nobody is a beginner. Once you've done a cardiology, and you on the visiting card you always read the senior cardiologist or senior intervention cardiologist. I've yet to see anybody with a junior intervention cardiologist. Nowhere it's written. Anyway, so we are all senior enough, and at this stage, if I attempt to do a fetal echo, one suggestion is that you need a support of a radiologist or a gynecologist or a fetal medicine specialist, because a lot of things would happen I was fortunate enough, my wife being a radiologist from PGI, so she actually pulled me up into this field, and this didn't come by choice, this came by default. And the second reason was there was nothing happening in echocardiography. It was a kind of a dead field long back, and now there's a lot of development. And that time I was looking for some challenge, and fetal echo did give me that opportunity. So if you are looking for that kind of an opportunity, you need to associate with one fetal medicine specialist or radiologist or a gynecologist who is doing rest of the fetal ultrasound, and you have to work in collaboration. So that is one. Number two, if you are trying to do a fetal echo with a basic machine, please forget it. You have to have a high-end machine. To tell you the truth, I called all the three vendors. I did the echo on same patient on all three machines, high-end machines. In the practice for such a long time, I could stretch that muscle. So all the three machines were there, and I could see where the differences were. That time I chose Samsung, and everybody was really surprised, what are we doing? But let me tell you, all the images which I've shown on this are from high-end machine of Samsung. The Philips at that time did not give me an adequate machine. GE also, they're excellent for radiology, excellent for that matter. My wife uses all the equipment, but I chose to do that. At that time I was using IE33. I didn't find it comfortable to do fetal echo. The images was too grainy. Okay, so then choose the right machine, and then you start exploring. First, you scan fetus between 24 to 28 weeks of gestation. The size is reasonable, and after 28 weeks there is a lot of bony shadows. You would get shadows of the ribs. You will get, because the ossification and calcification start happening, and you'll get a lot of shadows, and the image is not very clear. So what you do is that choose first patient should be between 24 to 28 weeks of gestation for your practice. Okay, that the size is reasonable, the quantum of blood is good. Then I use a power Doppler in majority of the cases. For power Doppler, it is something like seeing an amplitude mode. And I commonly give an example: if single person is singing in the same frequency, but if there are 100 people singing in chorus, the frequency is same, but they are loud. Okay, so what in the pulse Doppler or a color Doppler, what we pick up is a frequency or a frequency shift. What we pick up in power Doppler is how many people are singing in the chorus. Okay, we are seeing the amplitude. So in the fetal circulation, the velocities are not high. The frequency or the Nyquist limit is low. The Doppler shift is not very high. So you would prefer using a power Doppler. The RBC number is good. The chorus is the number is good. The RBC number of RBCs are traveling in one direction or other. So use power Doppler. So three things. One is that an association with the person who is doing ultrasound of the fetus. Two is that choose a high-end machine and choose it very carefully. And three is that practice between 24 to 28 weeks of gestation. And four, use power Doppler in gestation less than 24 weeks. Thereafter, the blood velocities are high. You can use color Doppler also. So that is said the question number two. Question number one, probably, we don't do the arch views very frequently. It is generally not required. If I am looking at the aortic arch, for example, and there is a, let's say if I say that there is a coarctation of aorta, there is an isthmus narrowing, I put the color Doppler on, because pulmonary artery and aorta are lying side by side, very close in that area. I would get a flow overlap of the pulmonary artery also. So it would look like as if the isthmus is not narrowed. So recommendation is use a 3-vessel trachea view, which is a cross-sectional view. It is the 4-chamber view. You angulate cranially, you would get an LVOT view. You angulate still more cranially, you would get an RVOT view, an origin of the pulmonary artery and the pulmonary valve. You angulate again a little further, and or maybe move the probe a very small distance up, and then rotate slightly to the left side of the fetus, and then you would get a 3-vessel trachea, which forms a V, and the SVC flow is generally not seen because that is actually perpendicular to your direction of the probe. The pulmonary artery and pulmonary veins are parallel to your, you would see them very, very clearly on that view. So practice a 3-vessel trachea view, which is very, very important in making the diagnosis.
Which is a probe which you use, Dr. UP?
I started using with the first my echoes, the fetal echoes was with IE33, so I used that pediatric probe. I think it's 3 to 8 megahertz probably. I don't remember. It's not a neonatal probe; it's a pediatric probe. But then I bought this Samsung machine, so I'm not promoting anybody for that matter because I think you guys need to know what I'm doing. So I'm just bringing my heart out. So when I started using a Samsung, I took that curvilinear probe. So the curvilinear probe I'm currently using, which the radiologists are using with a 2 to 9 megahertz frequency. If some radiologists are actually planning to see a fetal heart, or they're doing a small gestation or early week gestation, they've started using a linear probe. If I take you back into the history, the linear probes came first. The lines are linear and they have the highest resolution. We wanted more view. We wanted more extended view. So we started we make those linear probes curved so that we could span out. In the heart, then we could not use either because of the footprint. So we wanted a very small footprint probe which can fit in the intercostal space. So we had a cardiac or a sector probe. So sector probe, obviously the beams are diverging, so the resolution would not be as good. So for us, curvilinear is fine.
Now, most of the machines, you have to choose a preset, whether it is abdomen preset, cardiac preset. So what preset do you use for fetal echo? It is the cardiac preset or abdomen preset?
Ever since, I tell you what happened when sorry, I'm taking a little time, but that is the history. That's how the things happen. I left PGI and, I started working in a unit which had a color Doppler, and in PGI we didn't have a color Doppler. And that place, I didn't have a predecessor who could teach me how to use the machine. I did not have an engineer because this machine was imported from outside, the refurbished equipment. So there was nobody to guide me how to use the machine. So I created my own presets. I created my own algorithms. So that's how, ever since I get a machine, I create my own presets. I don't depend upon the presets what were there, but all the equipments would have a preset for a fetal echo, fetal heart. But if you are setting the preset, I tell you few important things what you do. In the fetal heart, I've created 2 presets. One preset is for a high velocity flow, which I use in a 4-chamber view and a 3-vessel view, because the velocity is reasonably high. If I keep the Nyquist limit low, it would mess up the entire thing. The aliasing would happen at a very low frequency. Then I have a low frequency or a low velocity preset. I call it low velocity preset. In that preset, what I've done is that the Nyquist limit is low. I keep the balance, which is higher towards the color Doppler. I keep smoothness very high. I keep the ensemble high. I keep the line density high. So now this preset is meant to look for a low velocity signal. And these low velocity signals actually are, when I scanning back, I want to see an URSA, which is the low velocity. I want to see SVC, which is low velocity. I come back and I see the pulmonary veins, which are low velocity. Then I see the DV, ductus venosus, with low velocity. So how I sweep, I start with high velocity scan, and I always use side by side, 2D and color, because that doesn't drop the resolution. So 2D is a standby alongside, because that gives me a guidance where the color flow is coming from. So now I start scanning with the high velocity preset, screen from abdominal view, 4-chamber, LVOT, RVOT, 3VT, little above 3VT. And then when I come back, I choose a low velocity preset. So now I start seeing SVC, then look back to the fourth chamber view, see pulmonary veins, back to the abdominal view, I see the ductus venosus. This is how I do it.
Okay.
So,
So as a
I have
diagnostic, you are sorry. No, go ahead.
I have a question. There is some American guidelines say that you have some time limit of around 5 to 10 minutes, and for teaching you have a time limit of 1 hour. So if you exceed that time, then how nearest you can do the repeat echo? You can do it on the same day after a few hours, or you have to take a week off. What is your take this? And another question I would like to ask is, do you routinely perform myocardial performance index, and what is its implication of the prenatal as well as postnatal course of the fetus? And the third question is, do Western biometry standards apply to the Indian fetus?
I'll reply to all these three questions, and I again have a habit of replying with the history. Okay, the very first question is about the biomedical issues with an ultrasound wave, and I did an ARDMS because one time I thought, let me go to Canada, and so that time the physics is the major component of that. I had to clear that physics paper before you could attempt anything else. So the physics actually helped me a lot in screening of a fetal heart. That knowledge of physics. Now, you were talking about mechanical index and thermal index. So now you on the right of the machine, top of the machine, most of the equipment would mention what is it's mandatory to mention mechanical index and thermal index. That means, so now you should know which is producing highest mechanical index. Mechanical index is that when the ultrasound wave goes and it actually can produce vacuolation in the tissue. Okay, that's what is your concern. Thermal is that increases the temperature. Pulse Doppler, in particular, is the highest incidence of mechanical and thermal index. So you avoid Pulse Doppler. The next in the sequence comes either power Doppler or a color Doppler. They are using the same technique. The next, the third would be, the least would be the 2D. So if you avoid color Doppler, you avoid Pulse Doppler, and you are conscious enough that you use color Doppler for a smaller time. Having said that, there is no documentation till date that ultrasound has actually created any kind of harmful effects. There is no documentation yet. And spending 3 times, probably if you talk about risk-benefit ratio, the benefit is far higher than the risks I'm taking. So I am conscious about the fact that I have to scan for a smaller time, stop for a while and do it again. And fortunately, these effects are not cumulative, like a radiation. So the effect goes off whenever you stop. So stop and do the exam in pulses. I think you would be reasonably sure. And you would be examining the fetus 3 or 4 times only if it is abnormal. The commonest abnormality missed. What is the commonest abnormality missed anywhere is the second one. You are so engorged in the first abnormality, you miss the second one. So that is a clue that you examine the patient. As a policy, I always examine the fetus twice, even if I made a full diagnosis. And in about 30% of the patients, I picked up an abnormality. But when I'm presenting cases like this, 5 to 10% abnormalities I pick up that time in the videos. Can you imagine? So that is what is the. So you would need to repeat it. So that gets me back to the biometry. The biometry, you are absolutely correct. The biometry is Western data, and we have to actually have our own data. If you are referring to the biometry, like radiologists calculate the weight and other things by abdominal circumference and head circumference and femur length. I know all that because everything is discussed in lunch and dinner time with my wife. She keeps on talking about it. All right. So now, if you use the Western data, now there is an Indian data available. Dr. Suresh in Chennai has developed a software. We are using that software only. They have incorporated Indian data to calculate the weight and other biometric parameters. So we are using Indian data now. We have a very large number of Indian data unpublished. That is not a published data that is used in the software, and software improves on that. And if you're talking about the cardiac, we don't have a biometric data from India. We have a Z-score. There is a site on a fetal Z-score where you can actually take measurements of pulmonary artery and aorta. Okay, so those Z-scores are again from a very small group of studies. So that's why taking measurement in fetal heart is generally not recommended because we don't have a data there. I hope I answered. Was the third one? There was another one.
Performance index.
Yeah. TI index or myocardial. Myocardial performance index is we do it in patients where we suspect the LV and RV dysfunction, or the patient has a disease where it's likely to. We don't do it in every patient. And for TI index also, there are a lot of refinements have happened, and people have started using the aortic and mitral clicks rather than flows, and that is said to be more accurate. And we do TI index regularly. On the right side, it's slightly difficult because you are not seeing the TI index on the same beat when the beats are different, and then we say, okay, we try to keep the heart rate almost the same when we do, and we do it regularly, TI index, for a subclinical LV and RV dysfunction.
So, I'm Hitesh. I have a question for you, sir. Two questions rather. First of all, congratulations, sir, for the nice presentation. You did kindle a lot of enthusiasm in a lot of hearts, I'm sure. And many will be, from now on, may plan to build up a future fetal echo program in your centers. So I have a question, sir. What is the usual time you spend in a particular patient, usually? And the second question is, what are the medical legal aspects you want us to be cautious about if we start it? Like the basic minimum views you should be taking. And yeah, those are the two questions.
All right. My experience with others and the other colleagues, now I'm in a part of that fetal society family. So we keep sharing things with each other. One is that the usual time depends upon the position of the fetus and how are you placed in that learning curve. So once you kind of plateaued, and then there's another one thing what I suggest. Once you're doing a view, for example, I'm scanning the abdomen and the cross section, and I'm going to the 4-chamber view. I should anticipate while I'm making a sweep where I'm going to find LV and where I'm going to find RV. From RV, when I go up LV, RV, 4-chamber, I must anticipate where I'm going to find aorta and where I'm going to find pulmonary. So in anticipation, if you move, this works as a kind of checklist. Okay, you know where it is going to be, and suddenly you see, oh, it's not there. Rather than seeing a structure and thinking that, okay, is it in the right place or not, you anticipate one move in the chest. Okay. So second is that the average time in a now is about 5 to 10 minutes. In a apical 4-chamber view and a good view, it doesn't take long, and you are seasoned enough. But for a beginning, I think it should take about 15 to 20 minutes. In difficult patients, hours. Okay, you see the patient. There are patients for both my side and radiology, those who come in the morning and go in the evening, because the position is not, and baby suddenly stops cooperating with you, would not move to an ideal condition. So that time frame is very, very important. And the precautions, right? The biggest precaution is PNDT. Okay, all law, common man, society, media, government, all are against you. You have to protect your skin. First your skin, then patients. That's what Dr. George used to say. Dr. Parale, you remember that?
Yeah, I know.
First save your skin, then patients. All right?
Yeah.
Okay. So now what you do is that you be very careful, and if they are association with the person who is doing a radiology work, so they can guide you on a PNDT. We have a proper, staff dedicated for PNDT work. I have 2 persons, those who are dedicatedly working only for PNDT. They have nothing else to do. Okay. So then after that, I had a couple of problems. It's not that I didn't miss. I missed one patient of tetralogy of fellows in an obese patient, which was about 92 kg. She was diabetic and having injections, and there was scarring. So further creating a problem of resolution. Then postnatally, the pulmonary artery size was as big as aorta. So if you have a PA size as big as aorta in the fetus, because the main diagnosis is in small pulmonary artery, how would you pick up? So that's why. And then from there, I realized I started mentioning 3 things. Thing 1, what is the weight of the patient to save my skin? 2, what is the window? Adequate, inadequate, or poor? Acoustic window. Okay. 3rd, what time did I spend to scan my the technician or a person who is standing there would write 15 minutes. If I scan it again, plus 13 minutes, plus 20 minutes, plus. So I can protect myself saying I did spend a good time, have the best machine, have the best knowledge. These are the errors which can happen. So these are the precautions. I hope this would answer your.
Which diagnosis, Dr. UP, you are allowed to miss, I will say. Then you won't be held responsible.
Actually, none. The consumer thinks that you are holding baby's heart in your hands and you are looking at it. And you did not look at the heart from the left side and right side properly. That's why you missed it. It's only in the court you have to go. The issue is that there are 2 steps. One is that how do you avoid going to the consumer court? Step 2, how do you protect yourself in consumer court? Okay, so that's 2. So the disclaimer has to be there in the machine that you are likely to miss abnormalities which are actually not possible to pick up in the prenatal period. Smaller things like a bicuspid aortic valve, things like ASD, things like PDA, which are there, already there. You can't pick up these abnormalities. Then almost all abnormalities nowadays can be picked up. I wish I had shown you. We could see fetal coronary arteries also. I had
small VSDs.
No, small VSDs are missed. Even the biggest problem is sub or a perimembranous VSD. Is a large VSD. A large perimembranous VSD is fairly commonly missed because there is a dropout and pressures in LV and RV are the same. There is no clue on the 2D and the color Doppler also doesn't come to your help. So then it's a problem. So that is why in that patient of TOF, the subaortic VSD was also missed and the pulmonary artery size was same and the pulmonary artery stenosis was also missed. So now, you're not allowed to miss anything. Yeah, please.
Many times, first study, you don't get anything. You are suspecting because there's a strong indication for fetal echo. So how safe it is, you call again and again? Because some disorders become clear in 2nd, 3rd trimester also, such as LVH because of diabetic mother. So what is your protocol in general? If you have not picked up, we are not sure, then we want to call again. What is the average protocol you are following?
The ideal time to do fetal echo is 24 weeks, but that is too late according to the Indian scenario, because in case you find something grossly abnormal, hypoplastic LV or something, you can't do anything, you have to continue. So we actually are forcibly pushed to less than 20 weeks of period, and we want the best time we do is between 18 to 19 weeks. You need to keep a margin for a patient to take a decision. You keep a margin for in case you find a right-sided aortic arch, for picking up a micro deletion or trisomy, you need time for chromosomal studies. So ideal time is between 18 to 19 weeks, and that's the full and final when you do. But many times patient come in 16 weeks. I do fetal echo between 15 to 20 weeks because of better resolution and experience over past so many years. And then if you do a scan on a 16 weeks or a 15 weeks, you must call the patient on in 19 weeks time, because we mentioned that a review fetal echo, and we, for a comfort, what we do is that we don't charge the patient second time. So I mean they don't mind coming again. They don't mind. And legally also I'm safe that I did suggest you to come back at that time. There are certain abnormalities like ductal restriction, that, for example, the tumor starts appearing very late. Congenital complete heart starts appearing very late. Coarctation signs don't come before 20 weeks of gestation. So all these things are to be seen later. Okay, so how do you, how would you get the patient? How would the patient be referred to you? Is by clinician who is doing an ultrasound or a growth scan, finds that heart is little abnormal. It's a cardiomegaly, right-sided is bigger. So no, he thinks that something is wrong. Let's get a fetal echo done and see what is going on. So third trimester fetal echo are less in number for all these diseases. What you said. In case you have a high previous history, or there is a history of tuberous sclerosis in a lady, or in a patient who is an SLE, we get that very frequently. The anti-RO and anti-LE antibodies, if are positive from the previous pregnancy, a person wants a second pregnancy. We don't discourage that, because incidence of second pregnancy having a complete heart block is just 11%. Okay, so I mean that's not very huge to stop them. So what we do is we do a PR interval, and we start from about 20 weeks of gestation, 22 weeks to be precise, and continue till 36 of weeks of pregnancy on a bi-weekly or a fortnightly basis to pick up the PR interval, because from PR interval to a complete heart block would be a very quick switch, and you would miss that bus. So we do ask them to repeat and write, mention, and at the courtesy, we don't charge second time.
Right. Sir, there's a question by Dr. Singh, how to differentiate between TOF and DORV?
I think what he is trying to say is that DORV of a variety which has a pulmonary stenosis and the normally related great arteries. Okay, so that is the DORV which can actually mimic or with the tetralogy of Fellows. The only difference is 50%. More than 50%, even in a neonatal listing, if you more than 50% override, you start calling it a DORV. Then there is an aorto, the mitral valve and aortic continuity. If the mitral valve and aortic continuity is maintained, this is tough, but it's very tough to pick up that in the fetus. Fortunate enough that it doesn't really make a difference in the therapy. It really doesn't make a difference, a great difference in the surgical technique when you have this type of normally related great arteries and tetralogy of Fellows. Like, so I don't think so. It's really, you don't put your head into it. You can mention and put it an oblique second possibility DORV.
Yes, sir. I think the questions will go on, but we have to bring this to an end, and we have spent almost 1.5 hours. It was really very intervening talk, because it generated so many questions. My professor used to tell me that questions get you the success of the talk. So
I think I would request the organizers to kindly send me the chat, and maybe I can reply those questions individually, or I'll send it. And I mean, they've spent so much of time, and the organizer can send me the chat, and I can answer those.
Sure,
offline.
I'll ask them to do that. Yeah. Thank you very much. And I
thank you
all the experts. It was a great time to be with you here. And the next class we are planning on 20th Saturday, 8 p.m. evening, and I have requested Dr. Y.C. Chandra from US to present his cases. So he's sorting out the different cases we'll have, and probably they'll be very good. And this was again suggested by Dr. U.P. Singh that you should request him for his cases. Let's hope, and let's see again on 20th Saturday 8 p.m.
So bye bye, Dr. Asif, Dr. Smit, Dr. Vivek, the Hitesh and our Dr. Parale ji.
Yeah, excellent presentation, UP. Excellent.
Thank you. Thank you.
Thank you.
Bye-bye. Bye.
Adrian.